A warm welcome you all for the next section. And today's topic of discussion will be in the internal rearrangement of TMJ. And I represent the Department of Dentistry. And today's topic will be regarding the most commonest pathology of temporomandibular joint. Now, before going into this topic regarding internal rearrangement, I would like to specify the components that is involved in this process. And as you all know, this temporomandibular joint is a bilateral gymo-diarthroidal joint, comprises of the condylar head of the mandible, the temporal fossa, and the disc. The lateral pterygoid muscle is attached to the head of the condyle. Now, briefly, you should understand that the temporal fossa, the condyle, head of the condyle, and the disc. This forms the crucial structures of the temporomandibular joint. Now, the six main components of the temporomandibular joints: the mandibular condyles, the articular surface of the temporal bone, the temporal fossa, the capsule, the articular disc, and the ligaments, and the attachment of the lateral pterygoid muscle beneath the head of the condyle. The six structures. Okay. The head of the condyle, the temporal fossa, the articular surface of the temporal bone, the capsule, the articular disc, ligaments, and the muscular part is with the lateral pterygoid attachment. And the term internal derangement, it is nothing but the disruption of the internal aspects of the TMJ in which an abnormal relationship exists between the disc and the condyle, fossa, and the articular eminence. Now, the definition part. Okay, if there is any abnormality associated with the disc, the condyle, the articular eminence forms the anterior guide for the temporomandibular joint. And if suppose any internal disruption is there, then the patient may end up with the internal derangement. That is the definition. Disruption of the internal aspects of the TMJ in which an abnormal relationship exists between the disc, condyle, fossa, and the articular eminence. And also termed as disc interference disorder, given by Weld and Bell. And before, like a brief anatomy about the condyle, the condylar process of the mandible. Okay, it is broad mesio-laterally, and it is narrow anterior-posteriorly. When you look at the head of the condyle, it is broad medio-laterally, and it is narrow anterior-posteriorly. That is how the structure of the condyle is. Lateral and medial tubercles provide attachment to the collateral ligaments. Thick fibroelastic covering of the fibrocartilage. This is regarding the structure of the condyle. Now, can you see the head of the condyle? It is broad mesiolaterally, and it is narrow anterior posteriorly. The lateral and the medial tubercles provide attachment for the collateral ligaments. Now, the next part is the articular fossa. The articular fossa roof is very thin. It is the bony structure that separates the joint cavity with the brain. Okay, and it is lined by a thin fibrous layer. This is the anatomy of articular fossa. It forms the roof of the temporomandibular joint, and it is the structure that separates the brain from the joint cavity, and it is lined by a thin fibrous layer. Now, can you see? Can very well appreciate the structure of the joint. Now, the next prominent part is your capsule. Okay, the capsule is a fibrous membrane that surrounds the joint and incorporates the articular eminence. And when you see the capsule, okay, it attached to the articular eminence anteriorly, articular disc to the neck of the condyle. This is how the capsule is related to the temporomandibular joint. The correct management of the temporomandibular dysfunction syndrome is depends upon two factors. Okay, any problem associated with the temporomandibular joint can be predicted with two factors. By making a correct diagnosis, and you should understand the nature cause of the disorder before treating any internal derangement. The diagnosis forms the trump card for your successful treatment outcome. The temporomandibular dysfunction is a collective term describing the problems that affect the masticatory muscles, the temporomandibular joint, and associated structure at both of it. It is a collective terminology. Temporomandibular, it's a broad terminology. Now, looking at the clinical criteria for the temporomandibular disorders. Okay. First is the pain. As all other ailment, the first and foremost symptom will be pain. There will be restricted in the jaw movements, in the limited movements, and for some individual you can expect a deviated path of closure, and that is one part. The other one is the joint sounds, abnormal joint sounds. Either it can be a clicking or it is a crepitus, and the other one is tenderness, that too in the temporomandibular region. The basic etiology, if suppose any trauma is there to the wall cavity, micro trauma, or any abnormal parafunctional habit or a bruxism, you can expect hypermobility of the joint. And if it is, it can be an osteoarthritis or inflammatory rheumatoid arthritis, ankylosing spondylitis, Reiter's syndrome, lupus erythematosus, or any infection that affects the temporomandibular joint. Like all other joints in the human body, a bacterial infection or a viral infection can lead to temporomandibular dysfunction. These are the etiological factors that should be kept in mind in bringing about a diagnosis. And it is also associated with psychological disorder. It can be a panic disorder, patient with an anxiety disorder, or alcohol abuse, binge eating disorder. If a patient is having insomnia or a sleep disturbance, that will also have an impact on the temporomandibular joint. Okay, the etiological factors, it can vary from a simple trauma or abnormal parafunctional habits, a bruxism, or can be due to any major trauma, or can be due to any psychological disorders. Like as we have discussed about the panic disorders, the patient is more anxious, or patient is under long-term alcohol abuse, and sleep disorders that will result in temporomandibular dysfunction. Okay. Now the next thing, okay, you should know the normal anatomy of the temporomandibular joint. Now, the first three parts we have dealt with: the condyle, the articular fossa, the articular eminence, the capsule. Then comes the prime structure, that is your disc. Disc is normal superior position when the posterior band of the disc is in the 12 o'clock position on top of the condyle in closed mouth condition. Now, when you look at when a person's in a closed mouth position, the disc will be normal superior position with the posterior band of the disc in 12 o'clock position. That means when you look at at rest, in other terms, at rest, what will happen is your disc will be in 12 o'clock position. That is what the diagram depicts. Now, if suppose any variations in the superior position, when the posterior band is anterior to the 12 o'clock position, see here. When the head of the condyle is moving forwards, you can see the posterior band. It will be anterior to the 12 o'clock position. And now the disc displacement. When does it happen? The displacement of the disc will happen when the elongation of the distal ligament and the inferior retrodiscal lamina, superior lateral pterygoid position, the disc more anteriorly. When this pull is constant, the thinning of the posterior border of the disc and displacement in more anterior position. This is regarding your disc displacement. And the abnormal joint sounds, it can be elicited during opening and closing of the mouth. Even in a normal range of jaw movements, you can see patient with clicking or crepitus. Or even when the tooth is brought to occlusion or very near to the intercuspal position, you can expect the abnormal sounds to be pronounced more. This is regarding the other clinical implication is patient will have a limited mandibular opening. Limited in the sense, before going into this, you should know what is the normal mouth opening of a patient is. It should be in the range of 42 to 45 mm. And if there is suppose a limited mandibular opening, that can be expected with temporomandibular. Now, it can elicit the history of the patient. Locking sensation whenever mouth is open too widely. And if suppose a patient finds difficult in bringing back his mouth closure. And the other thing what we discussed is the deviated path of closure. The mandibular midline shifts to the contralateral side at the very end of the mouth opening. When the condyle passes the articular eminence. The deviation is much greater and closer to the maximally open position than that is seen with disc derangement disorders. And after eliciting the abnormal joint sounds, the next clinical sign is you can elicit the deviated path of closure. In this picture, you can very well see the differing midline, dental midline. Okay, there is a shift. There is a that the midline shifts to the contralateral side at the very end of the mouth opening. When the patient opens the mouth, finally you can see the deviated mouth midline. And the another one is the spontaneous dislocation. Very often, patient will elicit the open lock, and that represents the hyperextension of the temporomandibular joint in the open position and preventing any translation. The other thing is the spontaneous dislocation of both the condyle and the disc, and can be due to hyperactivity of your lateral pterygoid muscles. It can be a simple yawning, as the lateral pterygoid is attached to the head of the condyle, that is beneath the capsule. That is where the lateral pterygoid is attached. If suppose any hyperactivity of the lateral pterygoid muscle is there, you can expect temporomandibular derangement. And if the condyle is brought anterior to the eminence, what will happen is there will be a tap. That means the condyle becomes trapped in front of the eminence, resulting in the patient inability to close the mouth. That means the head of the condyle can't be taken backwards, end up with a open lock jaw. The patient will be in a mouth open condition, unable to close his mouth. That is called as a open lock. That is called as a simple terminology is the lock jaw, or it is called as an open lock. And it is very commonly seen with patient of internal derangement for a longer duration. That too immediately after a wide opening yawning, or if suppose a patient is in the dental chair for a procedure that is lasting for more than half an hour, you can expect the open lock. This is very well can be the patient can't close his mouth. And the next condition is the inflammatory disorders of the temporomandibular joint. Either can be in the capsule, that is called as capsulitis, or in the disc, retrodiscitis, or it can be a synovitis. The inflammatory disorders of the associated structures, the stylomandibular ligament inflammation, or a temporal tendonitis. These are all the inflammatory disorders of the temporomandibular joint. And the first condition, the capsulitis. This is nothing but the inflammation of the capsular ligament. More commonly, tenderness of pain will be in the lateral pole of the condyle. When it is palpated, you can see pain and tenderness. That too, even when the joint is in static position, there will be severe pain. More commonly associated with any macro trauma. The reason for this capsulitis is a trauma that can be an open mouth injury. Now the other condition, that is the osteoarthritis. The most common degenerative joint disease. When you see this schematic representation, you can very well see how it destroys the head of the condyle. It's so severe that there will be a wear and tear of your head of the condyle. If suppose the other condition, that is the temporal tendinitis, if there is a prolonged activity of your temporalis muscle, most commonly associated with a chronic condition of a bruxism or a night grinding, or patients with increased emotional stress, you can expect the tendons to be inflamed. You can see a constant pain in the temporal region. The two behind the can be unilateral or bilaterally present. Like the treatment part of the is, you should more or less mostly it is a conservative management. It starts with an antidepressants, can add up muscle laxant, or can you go for a combination of drugs? More of a conservative management. And the other management of the temporomandibular dysfunction is you can give occlusal splints to the patient. The idea, basic concept behind this splint therapy is to reduce the stress, to temporarily disengage the teeth, give rest to the joint, reduce the spasm, contracture, and to reduce the hyperactivity of the muscles, most commonly the lateral pterygoid. What we simply tell is give rest to the joints, leave the joints, spare the joints. And the other use of this occlusal splint is to maintain the vertical height or vertical dimension of your occlusion. And that is what the use of this occlusal splint. It can be either a soft splint or a hard splint, and depending upon the clinical condition, we suggest occlusal splint ranging the thickness of 1.5 to 2 mm. The basic idea is to give rest to the joint, to disengage the teeth, to prevent the teeth from clenching or giving more force or trauma to the joint. The other treatment option or treatment modality is steroidal injection directly into the joint space, wherein the condition improves. A problem with the capsule or the disc, reducing the injured disc or the inflamed capsule, to bring in a good healing of your soft tissues that is surrounding the joint, including the initial treatment, the treatment line of treatment for this temporomandibular dysfunction. It starts with anti-inflammatory drugs along with antidepressants, added up with a muscle relaxant with a splint. A splint serves as an adjunct treatment for the entire process. And if suppose the patient is not feeling better, the next option is intersteroidal injection technique, wherein the steroidal injection is given directly to the joints spaces. And before concluding the session, I would like to brush up the basic things that should be kept in mind in bringing about a proper diagnosis that to a problem encountered in a temporomandibular joint. Only when a proper diagnosis is made, the treatment part will be successful. as I told earlier, most of the joint issues, the temporomandibular joint it is a multifactorial issue. No single reason can be or pinpointed for the problem that is encountered in the temporomandibular joint. It can vary from a simple loss of posterior teeth, wherein the vertical dimension of the occlusion is missed, ending up with a trauma to the temporomandibular joint. If suppose the number of teeth, there is a mismatch. If the premature loss of your posterior teeth, or if suppose there is hyperactivity of the muscle, most commonly the lateral pterygoid that is attached to the capsule of your disc, you can expect problems starting arising in the temporomandibular joint. And the other thing that should be kept in mind is I like to specify the importance about the correct diagnosis, which forms the success of the treatment. And before analyzing the abnormality, that is, you want to elicit the problem in the temporomandibular joint, the basic clinical symptom may vary from a mild pain or tenderness in the temporomandibular region with an abnormal joint sounds. Or before going to that, you should know the basic, how does the, in a closed mouth condition, how the disc will, and this is where the abnormal disc position is. This is where the abnormal disc position is, where the this is the picture that depicts the displacement of the disc. If there is a thinning of the posterior border of the disc and in the anterior direction, the end of the condyle slides anteriorly, you can expect the see, this is where the clicking arises. And the other thing that I kept in mind is the joint sounds can be during opening. It can be elicited in the opening of the mouth or in the closing of the mouth. If suppose something called as reciprocal click, 2 clicks that can be heard during opening and closing. When the patient opens, that time you hear a abnormal sound, a clicking. And even when he brings the teeth to occlusion, closing the mouth, you can expect the clicking. And I thank you for the patient listening. And I conclude this session regarding the temporomandibular joint internal rearrangement. Thank you. Thank you for your patient hearing.